Chapter 24, Dissociative Disorders. The continuum of self-concept responses is seen in page 279, figure 24.1. This is where it shows that there's still adaptive responses and maladaptive responses. For the adaptive responses, this is where there's like a positive self-concept, and finally in the very top of the adaptive responses is what we call self-actualization. In the other side, where it shows like depersonalization, which we will talk about later on, and identity confusion or identity diffusion, is part of the maladaptive responses. And in the middle is the low self-esteem. So in a normal situation, these small fluctuations, that's okay. Small fluctuations are normal because in our everyday experiences, we will go from, feeling positive or having that positive self-concept, or sometimes we would even go a little bit to the other side, which we will have some kind of identity diffusion or low self-esteem, and it's okay. That's normal. But as long as it's a small fluctuations in the continuum of self-concept, then we should be fine. It becomes a problem when the fluctuations is really big, where you're all the way up to like positive self-concept, and all of a sudden you're down to the depersonalization. So that is when it becomes a problem, or it becomes a mental health issue. And we will talk about those dissociative disorders and what are those things that are happening when we have, or the person has, that dissociative disorders. So self-concept, we did talk about having that positive and the negative self-concept. But what is self-concept? Self-concept are those all of the attitudes, the notions, the beliefs, and convictions that make up a person's self-knowledge. So again, low self-concept or the negative self-concept, it results in what we call maladaptive behavioral responses. What are some examples of self-concept? This is how you perceive yourself, how we perceive ourselves, like our behaviors, our abilities, like our unique characteristics. Like, for example, I'm a kind person, or I'm a good student, right? Those are like some examples of being having that positive self-concept. Where if you're gonna think about that negative self-concept, is like, oh, I'm ugly, or I'm very bad with doing something. Okay. Now in page 278, it did talk about the um, components of self-concept. We have the body image, self-esteem, self-ideal, personal identity, and role performances. And what are they? Body image is the attitudes and feelings about one's own body. Self-esteem is the judgment of one's own worth. And self-ideal is personal standards of how one should behave. Personal identity is a composite of behavioral traits and characteristics by which one is recognized as an individual, and role performances is socially accepted behavioral patterns. Healthy personality. Those people who have developed healthy personalities, they have learned effective coping skills and social skills that help them deal with life's challenges. And we call them resilient. Those people are called resilient. They are those individuals that are able to struggle with life's problems while they're feeling good about living. Now, mental health problems, they arise when these coping skills and the social skills are not learned, and negative and self-defeating behaviors become coping mechanisms. And this is exactly what we were talking about in this chapter right here. These dissociative disorders are actually happening because a person is actually not able to use that coping mechanism properly. So in return, what they would do is they would do something which is a maladaptive behavior, in order for them to try to cope with a trauma or whatever negative it is that happened in their life. Okay, self-concept throughout the life cycle. Self-concept in childhood, infant. This is trust versus mistrust, right? This is the time when they are learning to trust others, especially if the parents or the guardian or the adult is actually meeting their needs consistently. Then the infant is said to have the trusting ability, or they will build the trusting ability and skills to that adult that is actually meeting their needs. Toddlers, now this is the time when they're trying to explore the limits of their abilities, right? This is the terrible twos, where they would try to say, keep saying no, 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 and then they would try to actually try their limits. Now, this is the time where the parents actually plays a big role. Like, how are they going to actually deal with a toddler who's trying to explore their limits, trying to say no to everything, right? So, if the adult that is actually taking care of a toddler is also using some maladaptive behavior in order to deal with the toddler's behavior, then there's a chance that when they grow up, then the toddler is actually going to adapt that maladaptive behaviors. All right, school age children, this is the time when they become aware of different perspective in life. School age children, they learn the limits of acceptable behavior with the addition of new rules and limitations outside of their home environment. So it's very critical to have that consistency from teachers and those people that is around them outside of their home environment. And this is critical too, because those children who are, for example, being bullied in school, they can begin to develop a negative self-concept. Self-concept in adolescence, they in the early teen years, they will be comfortable. Self-concept of childhood is challenged. And again, it's very critical around these times, because remember, this is the time when the person or the teen is actually trying to look for their own identity, right? Who am I? If you guys recall, when we're talking about those stages of development. So at this time, the teens are always like, who am I? So this is also the time when they're trying to like learn their own personality and build their own skills, coping skills. So very critical around this time for them to actually learn that good self-concept, positive self-concept, and positive coping skills. Also in the adolescent stage, they are influenced by relationships, right? Maybe their own parents and siblings in their home environment, in the school, in their social relationship, maybe even start those romantic relationships. So they're influenced by relationships. Confidence, um, like we said, around this time, the teenagers are always very conscious with how the world actually perceives them. So confidence is very important. They need to build confidence. Sexual identity, again, going back to they're looking at this time, they're looking for their own identities. And body image. So body image, it's really important for the adolescent to be looking at their body image as a positive body image, right? Because if they don't, there's going to be a risk that they will develop those kind of disorders that have something to do with the body image. For example, a sleeping or an eating disorder. There will be a high risk that they will develop that if they have a negative body image. Self-concept in adulthood. Adults with a strong positive self-concept can freely explore their environment because they have a background of success and effectiveness. Whereas those adults with a low self-concept, they view the self as inadequate and incapable. Around this time, choices in careers and relationships are related in terms of where an adult falls on the continuum of self-concept responses. This is the time when the adult is actually like looking for their own productivity, their independence, their health, and maybe even death of people around them. Those are the things that can actually define him or herself um, when we're in regards to the self-concept in adulthood. Self-concept in older adulthood. In later life, many occurrences and situations can threaten a positive self-concept. This is an older adulthood. They've lived that long life, right? They have experienced a lot of things already. And so their self-concept has somehow actually already been built around this time. So is it a negative self-concept or is it a positive self-concept, right? Go back to the continuum of self-concept response. Is it actually an adaptive response or do they have maladaptive response to a trauma? Healthcare providers can enhance older clients' feelings of self-worth through active listening and demonstration of concern. Um, as healthcare provider, sometimes the best thing that we can do for older adult that is actually going through some kind of self-concept crisis is through active listening. Just be there for the patient. Active listening meaning you're actually listening to what the patient is telling you. You're asking them to elaborate if they tell you something, and the genuine demonstration of concern is very important for older adults to actually see as you as a healthcare provider is demonstrating some concerns. All right, now let's talk about the disorders. You have the dissociative disorders. First, what is dissociation? Dissociation is an attempt to cope with deep-seated emotional anxiety or distress. Low self-esteem is a common component of many health problems. So let's talk about dissociation. This is a type of coping mechanisms, okay? Now, when we're talking about dissociation, there's some normal behaviors that actually falls into this category. It's a normal behavior, even though you're having some kind of dissociation. For example, is daydreaming, right? Sometimes everybody does daydreaming, and it's a type of dissociation because you're actually trying to maybe forget something or trying to like avoid something, and what you do is you daydream, right? You think of something that is imaginary, so that is actually a normal behavior. Now if it becomes an extreme behavior that interfere with daily activities, then it becomes a dissociative disorder. It becomes a mental disorder. And those are the criteria that we as healthcare provider can actually use to identify if the patient is actually suffering from a dissociative disorder or is this actually just a normal behavior, right? Okay. Identity diffusion, just a terminology that we need to remember, is a failure to bring various childhood identifications into an effective adult personality. But before we move forward, please go to page 280, that box 24.1. Those are behaviors associated with low self-esteem. Please highlight this box and read it and know it by heart. Okay, going back to dissociation. So, one example of a dissociation is when a patient maybe went through a very traumatizing event, maybe a severe accident. What they do is they usually or they are unable to remember events surrounding the incident. That is one type of dissociation. They use it as a coping mechanism. What the body and the mind is trying to do is trying to dissociate themselves from that traumatic event. So what they do is they tend to like forget, those events that is actually surrounding the bad incident or the traumatic incident. The personalization disorder is another response to, or another way as a response to severe anxiety associated with blocking of awareness and fading of reality. This serves as a defense mechanism and can become a maladaptive behavior. So, during a depersonalization disorder, what happens is that the person feels detached or unconnected to the self. They usually say that they're like an automatic robot. They're working like a robot. Um, like they're moving, the body is moving, and yet the mind is actually detached from the person itself. It is a sense of being outside of oneself, a detachment from the body as if they're watching a movie. Um, if you can recall, like those movies where the soul or the person is actually stripping away from the body, this is actually what's going on with the personalization. Most of these people is actually saying like they're in a dream and they're actually just looking at their body as if they're watching a movie. Okay. Again, this is a type of a response to something that is traumatic, and what they do is this they try to kind of like stay away or steer away and block everything, block the awareness, and then fade the reality. Again, in page 282, table 24.2, these are behaviors that are associated with depersonalization, so please know them. You have emotional, social, intellectual, and physical behaviors. And know them, please. We need to know them. What's the difference between, the emotional to the social to the intellectual and physical behaviors that's associated with this disorder? Dissociative amnesia is a loss of memory. It is characterized by an inability to remember personal information that cannot be explained by ordinary forgetfulness. And most of these memory lapses are related to extremely stressful event. So one example of our dissociative amnesia is, for example, a patient that or a rape victim, for example, they don't have that memory of the attack itself. However, they still feel all those emotions that go with the incident. Like they feel sad, they feel depressed, um, they feel numbed, right? That emotional numbness. And sometimes they will even have those triggers like sights or sounds or anything that could actually trigger that emotional distress that they feel with the event. However, the event itself, the attack itself, is too painful for them to actually consider. So what they do is they, try to actually block that, um, and it becomes a dissociative amnesia because of the loss of memory of the exact incident itself. Dissociative fugue, this one is pretty cool, honestly. The word fugue itself means an escape from reality. Okay, dissociative fugue, it means an escape from reality. This is a sudden, unexpected travel with an ability to recall the past. Okay, it occurs in response to an overwhelmingly stressful or traumatic event. Extreme expression of the fight or flight mechanism is engaged to protect the individual, right? Let's look at this case study in page 282, and it's really cool, so I want you to read with me. And by the way, patients with dissociative fugue, they actually often appear as normal to those new individuals that they meet, okay? All right, case study, page 282. Amy was only 3 years old when she was first abused by her father. By 4, she was hiding whenever she heard his footsteps coming down the hall. At 6 years old, Amy slipped out the window to escape. On those occasions when he could not be avoided, Amy played a game in her mind in which she would fly away to a land where everyone was kind and carried no evil. She would wish and dream and hope during those times, ignoring the pain and distress of being repeatedly molested. By the time Amy was 13, she had run away from home. Luckily, early in her wandering, she found a youth shelter where staff members were understanding and had a genuine interest in seeing Amy survive her adolescence. She stayed at this shelter for about 7 months, learning the skills needed for adulthood. Soon, Amy became very efficient in coordinating and supervising the daily household events. Because of her newly learned organizational abilities, Amy was offered a job as a teacher's assistant at the local grade school. There, she remained for many years. By the time she was 30 years old, Amy had buried the memories of her abuse and forgotten the pain of her childhood. She was married and looking forward to a bright future. Amy's father became seriously ill the following year. He was alone and in need of care. After not communicating with her in more than 20 years, he wrote to ask if he could come and live with Amy and her family. The letter arrived, and Amy stared, horrified, at the return address. The rest is a blank. 6 months later, she remembered nothing more. Not the trip to San Francisco, not the bus ride to Colorado, not even her new fiancé. Today, she can hardly remember who she really is. Okay, so after we read that, there's a question here. It says, what do you think happened after Amy read the return address on the letter? And to answer this question, this is actually the dissociative fugue, right? In our mind, what Amy did was she went back to Colorado, or I'm sorry, she went back to San Francisco, where her father is, and from there, fugue happens. Fugue started, right? And this is when there's like a loss of memory of all of the events because they are in that state and they're trying to actually, avoid those traumatic events. So when she came back, right, to her actual life, that's when everything is like, um there's like a loss of memory. Like she cannot even recall what exactly happened, even though she made the trip, but she cannot remember the events that actually happened while she was in that trip, right? Because of there's like a traumatic event that is actually um, connected to the trip that she just made. All right, very, very cool. All right, dissociative trance disorder. This is a type of trance, right? Uh, Cultural trance are entered into voluntarily and cause no distress or harm to the individual. During trance, though, we need to remember that the individuals do not lose their identity. What happens during trance is that the patient just has no memory of when they are under the trance, right? When they have the trance, especially if there's like a possession trance, okay? And when this occurs, uh, when there's a dissociative trance disorder, this is what we call dissociative trance disorder. This occurs when the trances cause clinically significant distress or functional impairment. And what is trance, by the way? Trance is defined as a state of resembling sleep in which the consciousness remains but voluntary movement is lost. Okay, that is what we call trance. So you have culturally normative trances, which involve signs, symptoms, and behaviors that are expected by other members of a culture. And then there's a possession trance, which I just said earlier on. This involves the appearance of one or more distinct identities that direct the individual to perform sometimes complex behaviors and activities, such as culturally appropriate conversations, gestures, or facial expressions. So again, this dissociative trance disorder, this exists when those trances cause clinically significant distress or impairment. Okay, dissociative identity disorder. So with the dissociative identity disorder, this is what we used to call multiple personality disorder, right? It's called multiple personality disorder. What happens here is there's a presence of two or more identities or personalities even that repeatedly take control of an individual's behavior. Those personalities, presence of other personalities, they are actually present within one individual, and each personality is actually unique and represents the individual at a different developmental stage even. So you would even have patients that have dissociative identity disorder that have, for example, they have, oh, I have five personalities, or they have five personalities in one individual, right? And what happens is that those personalities actually will take turns into taking control of the individual's behavior. So, for example, a patient that have five personalities, one of them is a 9-year-old that is very playful. So if that 9-year-old actually takes control of the individual, then the behavior would change, right? Then the patient would start acting as a 9-year-old who is happy and playful. And what if the other personality is actually an old lady that is very grumpy, right? So now that personality, when that personality actually takes control, then the individual's behavior will actually change into that personality, like an old grumpy lady. Okay, so that's a dissociative identity disorder, formerly called as multiple personality disorder. All right, therapeutic interventions for this dissociative disorders. So what we do is long-term therapy that is provided in an outpatient setting, okay? Of course, if it's something that is in a crisis state, for example, aggressive, right? Aggression or violence, okay, that is directed toward the self or others and presents a danger to self and other, then that will be a time where the patient needs to be hospitalized, right? Or the individuals that are unable to function because of memory loss, rapid switching between identities, they have flashbacks or overwhelming emotions, and medications must be evaluated or adjusted. So these three things, or three bullet points here, very important for us to remember. Hospitalization is required so we can stabilize the patient around this time. Now, once the patient is hospitalized and the crisis is over with, then the therapy, it needs to be a long-term therapy, and this will be provided in an outpatient settings. More therapeutic interventions. So we have, like I said, the first one is should be an assessment, right? So we have to know if the patient is actually in the crisis mode for us to do, for us to decide, oh, is the patient needs to be hospitalized, or is this something that we can manage in an outpatient settings, right? So those two things that we need to remember is assessment and stabilization, especially if the patient is in the crisis mode. Then we're gonna do a revisit and rework past traumas. This is part of their therapy now. Pharmacologic therapy is when we give them some medications now to actually help control the symptoms. For example, the patient might be very depressed or sad, so then you can give something that like an antidepressant. Treatment is often based on symptoms, and all medications are prescribed only for short periods because of the side effects of all those medications that we have been talking about for mental health. You have your antidepressant, anti-anxiety, psychotropics, all of those things. We always just want to actually prescribe it only for short periods of time. Nursing therapeutic process or therapeutic interventions. Again, assessment is very important. Assessment should describe the patient's behaviors, communications, anxiety, depression, and social functioning, along with the presence of amnesia. Nursing diagnosis, very important for us to identify what is actually the patient's identified problems. Interventions are directed at helping them examine their situation and related feelings within an environment of safety and support. So, once we actually do our assessment, once we actually do the diagnosis, interventions like your therapies must be carefully chosen and can include maybe individual psychotherapy or group therapies, sometimes even family therapies if we need to, psychoeducations, medications, and then the what we call desensitization. Desensitization is when we actually slowly introduce like those maybe memory or something that has something to do with the events, right? But the keyword for desensitization is it's gradual and it's slow. Okay, we do it slowly. All right, sometimes we can also part of the therapy for the patient, we can also have like expressive therapy is what we call it, where the patient will actually express how they feel and what they're thinking through art or poetry or even dance, right? Okay, question one. According to Erickson, during the infant stage of development, what must infants learn? So the answer is one, trust versus mistrust. Question two. The nurse is caring for a school-age child. According to Erickson, what developmental task is this child trying to accomplish? Answer is two, to form a mental picture of himself. The nurse is taking care of a client who has an inability to remember personal information that cannot be explained by ordinary forgetfulness. The client's condition is known as what? Answer is two, dissociative amnesia. Question four. The nurse is working in a mental health facility. Her client is in a state that resembles sleep. The client is conscious, but voluntary movement is lost. The client's condition is known as what? Answer is three, trance. And that is the summary of chapter 24.